So, sir, we are starting with the session today. I request the attention of all the respected faculties and delegates. Kindly allow me a few minutes of yours and let me introduce myself and the faculty members of this session. A very good afternoon and a warm welcome to one and all. I'm Rituparna from Clarinet, the designated session assistant for a seamless experience. And Clarinet is India's most trusted and widely used digital platform with multiple enriching services exclusively for the doctors. Clarinet is very proud to be a digital partner for this webinar on PG case presentation organized by the National Neurology Forum, Gujarat State Chapter. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Kunal Ahia, sir, the Honorable Secretary of NNF Gujarat, to start the event today with his enlightening words and for the further coordination. Welcome you, sir. So, the is all yours. Please proceed.
Thank you, Ritu. Good afternoon, one and all. So, welcome you all for the PG case discussion. So, I would request Shwetal ma'am to say a few words, and then we'll hand over to Dr. Vishal, and he will be the moderator for today's session.
Thank you, Dr. Kunal. I welcome Dr. Karthik and Dr. Manan for today's session as an esteemed faculties. And Dr. Ashi, she's from our unit. She'll be presenting a case on hyperbilirubinemia. As this month we have decided to continue on hyperbilirubinemia. So I request Ashi to go ahead.
Thank you, ma'am.
Ma'am, if you permit, Dr. Vishal will give short introduction.
Yes, Vishal. Please. Sorry, Ashi.
Good afternoon.
Let Vishal introduce the speakers, faculties.
Yeah. Good afternoon, everyone. Okay. So today I think Dr. Ashi is going to present the PG case based on the neonatal hyperbilirubinemia, and her mentor is Dr. Vaishali Chandpura. She is an MD pediatric and currently she is working as an associate professor at Baroda Medical College. Her interest mainly is in neonatology and neonatal neurodevelopment in the pediatric and also pediatric epilepsy. Her teaching experience is more than 16 years. So I welcome Dr. Vaishali Chandpura, madam. The next esteemed faculty is Dr. Manan Parikh, and he is a director of neonatal as well as pediatric intensive Lotus Hospital at Baroda. He did his graduation and post-graduation from the Baroda. He is one of the gold medalists from the MS University of Baroda. He did his fellowship in perinatal as well as neonatal medicine from the Kokilaben Dhirubhai Ambani Hospital, Mumbai. He is one of the co-author of the Point of Care Neonatal Ultrasound and Neonatal Cardiology. He delivered multiple talks at state as well as national level at neonatal and nursing CME. His special interest is in holistic neonatal care, neonatal nursing, upgradation, and functional ultrasonography in neonatal in clinical settings. So I welcome Dr. Manan. Our another faculty is Dr. Karthike. He did MBBS as well as DNB pediatrics, followed by he did a fellowship in neonatology. Currently, he is working as a consultant neonatologist and pediatrician at GVN Riverside Hospital, Trichy. He did a multiple paper and publication. The interesting publication or paper, I think, on nephrology is on oxygen saturation and heart rate trend in the healthy late preterm and term neonate received delay cord clamping and immediate skin-to-skin contact in 2023 Telangana State Neocon. So I welcome Dr. Karthikeyan. And we will take a question at last. So I over to Dr. Ashi to continue our presentation. Ashi.
Thank you, sir. Good afternoon, everyone. I am Ashisha, third year resident in SSG Hospital, and I am presenting a case on neonatal hyperbilirubinemia, which is treated under in our setup under guidance of Dr. Vaishali ma'am. Baby of Kirti, which is a 6-day-old baby boy.
Sorry, you can make it full screen.
So click on the slide. So on the there's a third one.
Left to the 81%, what is written at the
Ah,
bottom of the screen, the symbol, you can click on it, it will become full screen.
Uh, just 1 minute, sir.
And in the bottom right of the screen, 81% is written. Left to it, there is a symbol. You can click on that.
Uh, 8 minutes, sir. Okay, sir. Hmm.
yeah, just click on that one. Yeah.
Okay, sir. Uh, Baby of Kirti, which is a 6 day old baby boy of Mrs. Kirti Baria from Galteshwar, Narmada, Gujarat, and referred from GMERS Godra on the 6th day of life for hyperbilirubinemia to our setup. Antenatal history of mother is a fourth gravida with an uneventful antenatal period, but just a history of first two alive male child of 5 year and second is of 2 years and not having any history of NICU stay. Third child which is expired on fourth day of life due to hyperbilirubinemia, but just exact cause of death are not known or any documentation not available. Baby delivered via normal vaginal delivery at 37 plus 5 weeks of gestation with a birth weight of 3.1 kg and cried immediately after birth. Uh, Presenting complaints. Patient was apparently well for 5 days ago, where mother has noticed yellowish discoloration of body and eyes. During first
Ashish,
2 days,
slide is not moving. Sorry to interrupt you. Ashish, the slide is not moving.
okay, sir. Just 1 second.
Even Ashi, you have to do the full screen slideshow. A cup
Yeah, the slideshow is not working.
icon is there.
Uh,
Yeah.
You
okay,
have
ma'am.
anyone else with you?
Yes, ma'am.
Just check there. See the your arrow is near to the cup icon.
Uh,
Also, you can click over there, like from beginning or something, you know. Yeah, from current. That's fine.
mm,
See,
uh,
what you can do is stop sharing your screen, and again you can start sharing your screen, and in that you select the full screen mode. What you have
okay.
done is you have shared the not the full screen but the PPT mode. So you can stop the sharing. Yeah, now
Okay, sir.
share it again, and in that you select your the one in which there is a full screen already there. There will be multiple options will be there.
Okay, sir.
No, it is the same thing is happening.
Same thing. Okay, sir.
I
No
think
problem. You
it happened to
continue.
our unit also, na Kunal. Is
Yeah.
same thing is happened to our unit also. So maybe some of the software is not working in the slide.
Okay.
So when you do with the Zoom meeting, so I think
Okay.
carry on with
Yeah.
this.
Carry on. No problem.
Yeah, no problem. We can see because you are moving the slide, so we can see that one. The in slide, so we can't see the another slide. So just carry on.
Okay, sir. Uh, Continuing, sir. Patient was apparently well 5 days ago, where mother has noticed yellowish discoloration of body and eyes. During first 2 days, dark stool was there, which turned greenish yellow on third day of life, but not giving any history of pale stool. Umbilical cord falls on fifth day of life. On receiving, some serous discharge was present from umbilicus. No complaint of lethargy or refusal to feed was there. Baby was referred to our setup for hyperbilirubinemia and was icteric up to palms and soles. So double surface phototherapy started and blood investigation signed. After 1 hour, serum bilirubin was found, which is 22.3 milligram per deciliter, which is near extent transfusion threshold. At 6th day of life, according to new AAP guideline, our extent transfusion threshold is 23.5 milligram per deciliter, and our serum bilirubin was 22.3 milligram per deciliter. So, according to escalation care, we just have continued with double surface phototherapy and IV fluids. Blood investigation shows mother is O positive with a baby of A positive and DCT ICT was negative, not having any history of consanguineous marriage. Birth vaccination was given and family history was positive with a history of one sibling female child expired on fourth day of life due to hyperbilirubinemia. Uh, Parents not giving any history of exchange transfusion, just giving history for phototherapy, and no other sibling, two other siblings not having history of hyperbilirubinemia or NICU stay. Social history. Baby is living with his father, mother, and two siblings. Mother is a 27-year-old and a housewife, and father is 30-year-old and a farmer. Mother living with a good family support, and they belongs to lower middle socio-economical class according to Kokuswamy classification. On examination, I examined baby in a mother's lap with a good daylight. Currently, baby is on room air and not required phototherapy. And today's weight is 2.9 kg with a head circumference of 33.5 centimeter and length of 48 centimeter. Currently on bright daylight, not having any pallor, but icterus up to upper chest was present. No cyanosis, no tachypnea and distress. Vitals measured, which shows BP of 68 by 40 and mean BP of 56, which is measured by NIBP on right arm. Heart rate was 148 per minute. Respiratory rate was 42 per minute, and SpO2 of 97% on room air, not showing any signs of shock, and CFT less than 3 seconds. Management. Uh, Soon after admission, double surface phototherapy started, and considering escalation of care, minimal feeds with IV fluid started. After 12 hours, change over to 50% feeds with 50% fluid, and serial bilirubin monitoring was done at every 6 hourly. When serum bilirubin is near phototherapy threshold, we changed over to single surface phototherapy and increased to full KS feed with breastfeeding. Our investigation on receiving blood investigation shows hemoglobin of 15.6 gram per deciliter with a total count of 13,500 and platelet adequate of 2.47 lakh, CRP of 43.42 milligram per deciliter. Uh, our bilirubin, which is serially monitored, which is shown in this table. On receiving, our total bilirubin was 22.3 milligram per deciliter, with a threshold for phototherapy is 18.2 milligram and threshold for exchange transfusion, which is 23.5 milligram per deciliter. Which is near exchange threshold, so we continued with a double surface phototherapy. After 6 hours, we again repeat bilirubin, which shows 21.8 milligram per deciliter, with a reduction of zero point 0.5 milligram per deciliter in the first 6 hours, despite of phototherapy, with a exchange same with a exchange threshold 23.5 milligram per deciliter. But after 6 hours, which is 12 hours from receiving, our total bilirubin is 18.3 milligram per deciliter, which is reduced with a zero point 0.3 milligram per deciliter per rate of zero point 0.3 milligram per deciliter per hour, and which is near phototherapy threshold. So we shifted to single surface phototherapy. At 24 hours after admission, our total bilirubin is 17.6 milligram per deciliter, uh, and threshold for phototherapy is 18.2, which is near phototherapy threshold, but within 2 milligram per deciliter of phototherapy threshold. So we continued with a phototherapy. At 36 hours after admission, our total bilirubin is 14 milligram per deciliter, which is out of with the range of plus or minus 2 milligram per deciliter from threshold phototherapy. So we omitted phototherapy. According to new guideline, in our case, we have a risk factor in which hyperbilirubinemia risk factor is ABO incompatibility, history of phototherapy in prior sibling, Asian race, weight loss of 8.5% in first 6 days, which is in physiological limit but on higher side, and history of poor feeding. Neurotoxicity risk factor includes sepsis, in which CRP is borderline high and having serous discharge from umbilicus on receiving. No other signs of systemic sepsis noted. In other investigation, we have done to rule out other causes of hyperbilirubinemia, which includes blood gas, which is done on receiving, which is normal with a pH of 7.37, which shows hemodynamical stability of the baby on receiving with a retic count of 1%, and G6PD enzyme activity was present. Total protein was 6.3 with albumin of 4.1, serum bilirubin and albumin ratio is 5.4. According to new guidelines, if it is more than 6.8, uh, uh, then we have to do exchange transfusion. But in our case, it has a 5.4. So we continued with the phototherapy. Currently, baby is out of phototherapy range and kept in a postnatal ward with a mother on feeds and antibiotics, gaining weight currently, and antibiotic is continued currently. Our culture report is awaited. Thank you, sir.
Archie, this is Dr. Manan here.
Yeah, go ahead, Dr. Manan.
Yes. Archie, are you there?
Yes, sir.
I want few more details from your case. Like this patient was admitted outside in peripheral unit.
Yes, sir.
So on what day this baby was admitted there, and what were the investigations there? And if they have given phototherapy,
Yes,
so
sir.
what was the fall of bilirubin and why they needed to transfer this baby to the higher center?
Yes, sir. Baby on sixth day itself, on fifth day, by evening they reached Godhra, where bilirubin was on higher side, and just hyperbilirubinemia was up to palms and soles. They started phototherapy, but their bilirubin was 29 milligram per deciliter, which is their report from outside. Which is in exchange threshold, above exchange threshold. So they shifted to our setup for further management. But sir, on receiving, our capillary bilirubin was 22 milligram per deciliter. So we just started phototherapy, and blood serum bilirubin was sent, and we further, our report was 22.3, which is near threshold for exchange. So we not taken call for the exchange transfusion.
Okay, fine. So
Baby received 20 hours of phototherapy at Godhra.
20 hours. Okay, and that
Yes,
was single surface, double surface.
single surface. According to parents, single surface.
Okay.
Okay, sir.
So we start with the history itself. Now we are dealing with a case of neonatal jaundice here. Can you summarize your case from history once?
Okay, sir.
From history.
Okay, sir. Uh, Sir, we received baby on the sixth day, uh, and for hyperbilirubinemia. From my history point of view, we have a first two positive finding with a blood mother blood group of O positive, and with a history of sibling death, which is not any documentation for that, but we have two positive finding. And for neurotoxicity, we have a sepsis, which is in a form of discharge from umbilicus with a weight loss of 8.5%, though it is in a physiological limit, but is on higher side. So, sir, on blood investigation, we have CRP on higher side. So, this is my positive points towards hyperbilirubinemia. And on receiving, child was active. Bind score was 0 by 9. After that, we normally manage the case according to hyperbilirubinemia.
Okay, good. So what is the importance of age in any case of neonatal jaundice presentation?
Uh, Okay, sir. Sir, if we found jaundice within first 24 hours, then we have to look for the causes, pathological causes of hyperbilirubinemia. And according to days, initial 5 days, range was gradually increased. So we required proper exact just days with an hour of life, and after that it is the same. But if jaundice is before 24 hours, so we should look for pathological causes.
Okay. If it is on first day, what are the causes
Karthik.
comes to your mind for neonatal jaundice on within 24 hours? what are the causes that comes to your mind?
Sir, it may be hemolytic jaundice due to ABO incompatibility or RH incompatibility.
Okay. Then any other causes?
Uh,
Presenting on first day
Yes,
24
but
within 24 hours.
here it's a ABO incompatibility or ABO setting because the direct home test was negative here.
Sorry, sir.
Here you are commenting about ABO incompatibility. So that
Okay, sir.
DCT test itself negative.
Yes, sir. In our
So
case,
other
it's
causes on any other causes on first day jaundice less than 24 hours? Apart from your immune hemolytic jaundice?
Anything, any test you want to do it on this baby, the sixth day, any screening that may be helpful for identifying some other causes also.
sir, we just initially ruled out obstructive causes by just serum bilirubin and direct and indirect bilirubin. Then go for USG to look for the same reason. Uh, then we have
Any roles of screening test?
uh, then we do on receiving septic screen. Then to look for hemolysis, we serially monitor our hemoglobin and hematocrit level with retic count. Uh, then we do albumin levels, G6PD. It is his male child, so we send G6PD.
Newborn screening test, that importance of newborn screening test here to rule out hypothyroidism, galactosemia, tyrosinemia.
Uh, Okay, sir. In our case, we send thyroid levels. Though mother having not any history of hypothyroidism, we send which is in normal limit. Other screening test
So
not there,
can
sir.
you categorize, can you say that significant risk factor for hyperbilirubinemia and the risk factor in neurotoxicity? What are the risk factors? Can you say it?
Sorry, sir.
Significant risk factors for hyperbilirubinemia and risk factors for neurotoxicity?
Okay, sir.
So,
All the factors or factors in our case,
in
sir.
this case, in our case,
Okay. Um, Sir, in according to new guidelines, our risk factor for hyperbilirubinemia was lower
Actually, your voice is breaking.
of more
Ashi, Ashi, are you able to hear us?
no, ma'am, her voice is not audible.
than 0.3 milligram per deciliter per hour is there or not. Patient was on exclusive breastfeeding. Hello.
આશી તારો અવાજ નથી આવતો.
હા મેમ એક જ મિનિટ.
તું ક્યાં છું?
મેમ
ડિપાર્ટમેન્ટમાં?
હું અહીંયા છું. હા ત્યાં જ છું. એક
હા
જ
તો
મિનિટ મેમ.
હા.
Am I audible, ma'am?
Yes, yes, you are audible, ma'am.
Yes, yes, yes.
Okay, ma'am. Sir, risk factor for hyperbilirubinemia, which has a lower gestational age of less than 40 weeks, or for exchange, it is for 38 weeks. Jaundice within first 24 hours after birth, or any pre-discharge serum bilirubin concentration close to phototherapy threshold. Um, if phototherapy given before discharge or not, parents or sibling having history of phototherapy, which is positive for our case, exclusive breastfeeding with suboptimal intake, which is also for our case, then any scalp hematoma, or any yes, sir. This is for phototherapy, and risk factor for neurotoxicity, which includes gestational age less than 38 weeks, then albumin level less than 3 gram per deciliter, then sepsis or significant clinical instability, or isoimmune hemolytic diseases, or any or G6PD deficiency. In our case, we have a sepsis only. Our albumin levels were more than 3 gram per deciliter, and we have a G6PD enzyme activity also present in this baby with a gestational
Okay.
age near to
Yes,
37 plus 5 weeks.
yes, yes, yes. Okay. So here, because this baby is fitting into that neurotoxicity risk factors, almost more than two risk factors are there. So one at the time of admission, anyway, you will plan for intensive phototherapy. So do you have any idea about what is intensive phototherapy?
Uh, just send the blood for to keep ready blood for exchange transfusion. Serum samples were sent, blood investigation, and IV fluids started.
That is escalation therapy. That intensity
Okay,
of
sir.
phototherapy is based on what parameters I'm asking.
Uh, intensive phototherapy, sir, distance of phototherapy from baby minimally, we keep 30 to 45 centimeters, but for intensive phototherapy
Yes.
we reduce the distance between this 2 to 50 to 20 centimeters.
First close to baby, and that narrow spectrum LED blue light that irradiates actually around 30 microvolts per centimeter square per millimeter, and the wavelength around 475. That is it.
Arshi, what are the
Sorry, sir.
characteristics of physiological jaundice?
So physiological jaundice, usually it is after 24 hours, and which resolves within 7 days, and presence which not up to palms or soles, with a serum bilirubin increase of more than 2 milligram per deciliter per hour, or more than 5 milligram per deciliter in 24 hours.
Physiological jaundice in preterms characteristics. Is it the same criteria we follow for preterm for
Uh,
physiological jaundice?
Sir, we mainly follow nice guideline for preterm babies.
So when do we call physiological jaundice in preterm and when pathological?
Mm, mm, Sorry, sir. Not no.
So preterm in physiological peak as in term occurs at fourth day. Preterm in it peaks at 8 to 10 days.
Okay, sir.
That is mainly because of immaturity of liver and larger volume load and persistent destruction of the hemoglobin. And second thing, in term it is up to 7 days. In preterm it is up to 10 days in physiological jaundice.
Okay, sir.
Any other difference in term and preterm jaundice?
Uh,
preterm tend to have more risk for what?
Sorry, sir.
Preterm with jaundice tend to have more risk for
Encephalopathy.
encephalopathy or neurological manifestation. And why so? Why they are at
Bilir-
more?
uh, Sir, preterm baby having immature blood-brain barrier, so they have a more prone for bilirubin encephalopathy.
Okay, one reason is immature blood-brain barrier. Anything else?
Mm. Sir, I have only.
Okay, so in preterm there is a shorter RBC lifespan and impaired
Okay.
coagulation, both of which increases total bilirubin. And
Okay,
preterm
sir.
have low albumin level compared to term babies. So free
Due to
bilirubin is
liver
also,
immaturity. Okay, sir.
and then the immature blood variant combined with these factors makes them vulnerable for neurological damage.
Okay, sir.
Okay, what is more dangerous, RH incompatibility or ABO incompatibility? And
Mm.
why?
Sir, uh, sir, RH incompatibility.
Yes, right. Why? Why RH is more risky?
Uh, Sir, in RH, mm, and mm,
Anything
sir, I
related to the
don't know.
antigen presentation? So
Mm,
all of our body tissue, apart from RBC, have ABO antigens expressed on their surfaces. And then anti-A, anti-B antibodies can attach to that apart from RBC. While for RH, it is only RBC where this antigen are present. So attack is only on RBCs. And that is why hemolysis is more, immune mediated hemolysis is more. And that is why RH is more severe.
Hello. Yeah.
yes, sir. Uh, Sir, RH incompatibility में antibody was more of IgG. This is the main reason.
The main reason is all other body tissue express ABO antigen in our body. So for antibodies, there are more sites to attach and less antibodies attack RBCs. While in RH
Okay,
incompatibility,
sir.
antigen is only on RBC. So there is more attack on RBC, only attack on RBC. And that is why destruction, hemolysis is more, and that is why jaundice is more.
Okay, sir.
So this is your patient that came to you. Birth weight was 3.1 kg. You received a 2.9 kg on 6th day. Will you consider this as
200.
breastfeeding jaundice?
Uh, yes, sir, because on 6th day, though it is on physiological limit, we received at 2.8 kg, which is 8.4% weight loss within first 6 days. Uh, with a baby was exclusively on breastfeeding and mother giving history that baby passes stool once a day or urine passes just 4 to 5 times per day. So we correlate with a breastfeeding jaundice.
Okay. And what is the difference between breastfeeding and breast milk jaundice?
Sir, breastfeeding jaundice, which is in baby with exclusive breastfeeding, with the inadequate feeding, and due to enterohepatic circulation, jaundice occur, and in breast milk jaundice, EBM contains substances which prevent uh, bilirubin conjugation and which leads to jaundice.
Can you name two such substances which leads to breast milk jaundice?
Uh, hmm, Sorry, sir.
Okay. So it is pregnenolone, free fatty acid, and
Okay.
increased glucuronidase activity in breast milk. That activates glucuronidase pathway and converts
Okay, sir.
bilirubin into lipid insoluble form.
Okay, sir.
Any specific neurological examination you did in this kid? Yes, this is uh, on sixth day with 22.3 bilirubin nearing the exchange range. What specific neurological examination you want to see in this baby?
Sir, on receiving, we perform that bind score, for which we just examine mental status, but baby was active, and mental status was normal, so just we scored 0. With a cry pattern, baby cried well, not having any high pitch cry or any shrill cry. So
Ashi, your voice is breaking again. Ashi,
perform a
Ashi, your voice
which
is
is
breaking.
in
Hello, can you hear us? Ashi,
Ashi,
uh,
Ashi, hello, Ashi.
yes, ma'am.
આ કેમ આવું થાય છે?
Am I audible, ma'am? Am I audible?
Ashi, your voice is breaking. Maybe some network issue. Do you have a proper
Uh,
network over here?
Sir, can I connect with my colleague's account?
શ્યોર.
Sure.
Okay, ma'am.
પહેલા કનેક્ટ થા પછી તારામાંથી લીવ થા.
Yes, ma'am. Am I audible, ma'am, from Janvi Patel's account?
Yeah, you can
Yes.
audible, so you can unmute yourself in your previous account. So
Yes, sir.
mute yourself, not unmute.
Okay, sir. Sir, for neurological examination, we just perform a bind score. In our case, it first is a mental status in which baby is active. So we just label 0, with a cry pattern of normal, not having any high pitched or shrill cry. So it is also 0. And with a muscle tone of baby is well flexed position. So also we label 0. No any hypertonia or hypotonia was noted.
And how do you score as per bind scoring? How do you score this baby?
Sir, our score is 0 by 22. So, which is normal. According to normally, if we interpret, so bind score 1 to 3, which is mild, 4 to 6, which is moderate, and 7 to 9, which is a severe risk for encephalopathy. But on receiving, baby is active with a well flexed posture and normal cry. So we our bind is 0 by 9.
Anything apart from bind score, neurologically you want to examine?
Sir, we
Or rather,
performed.
what
Huh?
are the presentation of bilirubin encephalopathy?
Baby having hypotonia, then absent Moro's reflex.
Hypotonia or hypertonia?
Sir, initially hypotonia, then later on hypertonia. Lethargic baby mainly. Then high pitch cry or any seizures, मतलब convulsion.
Okay. What happens to DTR, deep tendon reflexes?
Deep tendon reflex is mainly exaggerated.
Okay. Initial stage they are reduced and then later on stage they are exaggerated.
Yes.
Fine. Now supposing if you received this child outside 29 bilirubin and now you did your blood investigation, it is also 29. And obviously it is newer chart, older chart, whatever, it is coming in exchange range. So
Okay, sir.
how do you prepare for exchange? In terms of your procuring your blood, which blood and how much amount?
Sir, first we start our management and send blood investigation. For exchange transfusion, it is double volume exchange transfusion, in which if preterm baby, it is 100 ml per kg blood into 2 for double volume, and in term baby, it is 85 ml per kg. And for blood grouping, it is mainly of mothers ABO and baby's RH grouping was taken for exchange transfusion. So mainly we send mother blood samples and baby samples to lab so that they reconstitute the blood or else whole blood, and uh, we then from that blood we exchange the baby's blood.
Okay, if we are going to a delivery of a RH negative mother, fourth gravida,
Okay.
and you want to keep blood ready for exchange if in case it is required at early stage. So what blood will you keep ready for such delivery?
Sir, O negative blood.
ORH negative.
Yes, sir. Because we don't have the baby's blood group, but mother is RH negative. So
Okay. And any one specific peculiarity of blood when you select or when you call the blood bank? It should be as fresh as possible, not more than 5 days old blood,
okay, sir.
but as fresh as possible.
Okay, sir.
The ideal indication for exchange transfusion, when you will think about exchange transfusion, what is the definitive criteria I'm asking?
Okay, sir. For exchange transfusion, if first of all, if our bilirubin was on higher side and above the threshold for exchange transfusion, then second is despite phototherapy, if bilirubin is still in increasing trend, and not decreasing significantly by 0.5 milligram per deciliter, or if any first cord bilirubin was more than, for RH negative blood pregnancy, cord bilirubin was more than 5 milligram per deciliter, then we go for exchange transfusion.
Okay. And signs of intermediate and advanced stages of acute bilirubin encephalopathy, those time also. Okay. So once you arrange all the blood, all the things, before transfusion, that baby's bilirubin levels are decreasing. So almost 2 points are decreased from that initial pains. Whether you will go for exchange transfusion or you will wait.
Sir, we wait for exchange transfusion because bilirubin is in reducing trend.
Yes, correct. Because the exchange transfusion leads to a lot of complications. So always, whenever the range is decreasing, we should wait for.
Okay, sir.
Any
Actually, what are the
indication for partial exchange transfusion?
Sorry,
In
sir.
all negative setting, partial exchange
Okay,
transfusion
partial.
in negative settings.
So partial exchange transfusion, we mainly if polycythemia with a hemoglobin of more than 22 gram per deciliter or hematocrit of more than 65 with symptoms or
That is
more than.
polycythemia. I'm asking in antenatally mother is detected RH negative pregnancy. So we're going to
Okay.
attend the delivery. So
Hmm.
that time you either you will plan for double volume exchange transfusion or partial exchange transfusion. Some definitive indications are there for partial exchange transfusion also. So what are the indications I'm asking?
Mhm. Sorry, sir, that criteria I don't know.
Three criteria are there. If baby is antenatally developed hydrops fetalis, and at the
Okay.
time of birth, baby is having congestive cardiac failure, and that baby hematocrit is very low, so that
Okay.
hemoglobin itself less than 5, then that time you need to go with partial exchange to compromise that baby's heart. Then you need to go for double volume exchange transfusion.
Mm. Okay, sir.
Arshi, what are the mechanism of action of phototherapy when you give phototherapy? How do it reduces bilirubin?
Sir, by structural isomerization, it
What
will
happens?
convert unconjugated bilirubin for convert to lumirubin, and which is water soluble, so excreted in urine.
Any other mechanism?
Sir, one is the structural isomerization, and second is photoisomerization.
And third one is
Third one is sir, photo oxidation.
oxidation. Only oxidation. Fine.
Okay. Okay.
Whenever you keep your baby in under phototherapy, what
Hmm.
instruction do you give to your staff?
Okay. Sir, primarily whole body is exposed for the phototherapy. We have to check for the hypothermia also, and phototherapy also causes retinal damage. So ensure for the eye patch every 2 hourly. Uh, मतलब, temperature monitor for temperature regulation, sir.
Anything else?
Mm, sir.
You have to ensure
Okay, sir.
hydration and feeding.
Feeding. Okay, sir.
Second thing, distance from phototherapy
Okay.
to skin, because that is what ultimately ensures faster
Uh,
decrease in the bilirubin.
yes, sir.
And stool color. How stool color changes after phototherapy?
Uh, sir, stool mainly uh, color not changes or somewhat become pale, but mainly color not changes after phototherapy.
So after effective phototherapy, your stool color is greenish. Your all three mechanism, photoisomerization, structural isomerization, oxidation, the
Hmm.
bilirubin is now dissolved, converted to lumirubin, and that all are green in color, excreted in your stool, and your stool
Okay.
color will be greenish. So
Green.
it is indirect marker that your phototherapy is effectively working, and we are on coming down on bilirubin trend. Indirect mark, not obviously we have to see the bilirubin level, but
Okay,
stool
sir.
color changes to green.
Okay, sir.
What is rebound phenomena
So do you
after
know about
stopping?
home phototherapy?
Uh, Home phototherapy. If sir, bilirubin levels were near phototherapy, so just we not have to admit the baby in NICU. We just keep baby with mother.
Yeah, but some indications are there for that phototherapy, home phototherapy. The baby gestational age at least more than 38 weeks and received any phototherapy in hospital. So, and the duration usually that babies develop. The main purpose of phototherapy to keep the baby along with mother side.
Okay, sir.
Do you use transcutaneous bilirubinometer, RC, at your institute?
Yes, sir. We use transcutaneous bilirubin.
What is the mechanism of action? What is the principle of that instrument? How it measures bilirubin?
Sir,
And any
sorry, sir.
fallacy of that instrument when it gives unreliable result?
Sir, within first 24 hours or in a preterm, then if baby is under phototherapy,
And dark color skin
okay, sir.
and thick skin.
Thick skin. Mm.
It acts on principle of reflectance. It delivers the light of 400 to 700 nanometer to the skin, and then bilirubin absorbs the light, and whatever light
Reflux.
is reflected back, that machine measures the difference, and according to that it gives to your transcutaneous bilirubin measurement.
Okay, sir.
Okay, what is rebound phenomena? You're given your patient is phototherapy now at 14.1 is top phototherapy. What is rebound phenomena?
Sir, initially we just give phototherapy. So bilirubin reduces, but we have to monitor for the first 24 hours for rebound bilirubin, which again escalate to in phototherapy range.
Okay, any specific number we are targeting from after stopping?
Sir, if it increases by 2 milligram per deciliter,
Yes.
then we labeled it by rebound.
So rebound is usually up to 2 to 3 milligram per deciliter. If it is more than 3, then you have to think, and we may need to restart the phototherapy.
Yes.
What is yellow alert? You know what is anything about yellow alert
No, sir.
related to your direct jaundice?
Sir, if direct bilirubin more than 20% or a 1 gram per deciliter, then we should look for exact
1 or
yellow.
2?
No.
1 or 2? It is 2.
Okay, sir.
There is definition, or that is by how you rule out conjugated, unconjugated. But what is yellow alert? Do you know anything about it?
No, sir.
Okay. So when you have icteric baby, more than 14 days, icterus persistent in term baby, more than 21 days in preterm baby.
Okay.
There, if your indirect component is high, that patient is in yellow alert and it needs to be referred to a proper higher center, and where we need to rule out treatable causes of conjugated hyperbilirubinemia. Because if it is biliary atresia or something surgical, then we need to undergo Kasai or corrective surgery within 60 days to provide maximum good result to the baby.
Okay, sir.
So any jaundice more than 14 days in term, 21 days in preterm with direct component, you need to evaluate for surgically treatable causes of conjugated hyperbilirubinemia. That is what is yellow alert for us.
Okay, sir.
So last question from my side, that this is the patient, 6th day of life, you received with 21, you treated within 48 hours, brought down to 14.1. You are
Yes,
happy,
sir.
parents are happy. Now
Okay.
you have the history, parents have the history of losing one kid for phototherapy due to hyperbilirubinemia. We don't know the cause, they don't know the cause. And
Yes.
parents are now asking you, સાહેબ મેડમ મારે પેલા બચ્ચા જે બાળક છે તો કશું નહીં થાય ને. How will you
Mhm.
ensure them, or what will you do, what extra taste or things you check before giving any answer to them, and how will you counsel them for this baby?
Uh, okay, sir, we when, up to when baby is with in our setup, we just monitor by capillary bilirubin for the for that, or also we perform BERA before discharge to rule out any or toxicity or other causes for bilirubin. We just have ruled out. So then we just say that these reasons are not there, but
Any specific test you will perform before concluding anything to parents?
hmm, hmm, sorry sir, no idea.
Basically they are worried કે last time baby expire થઈ ગયું, હવે આ baby તો expire
Ah,
નહીં થઈ જાય ને. So we
yes.
have to look into the causes of hyperbilirubinemia which can lead to death. Which are those
Okay.
causes? Which can lead to death in hyperbilirubinemia?
That mainly to hemolytic or G6PD, but sir, we ruled out other cause. Sir, I don't know.
One final question from my side. If you do MRI connectress baby and another MRI for HI baby, what major areas will get affected in connectress and major areas will get affected in HI?
Sorry, sir.
Dr. Karthi, your voice is breaking, so
So,
can you repeat the question?
yes, yes. So in connectress, what are the MRI findings? Like which common areas will involve in brain, and in HIE, what common areas will involve in brain?
Uh, Sir, mainly it involved globus pallidus. And abnormal signals in globus pallidus and hippocampus with subthalamic nucleus mainly.
Yeah. So in HIE, it's mainly cerebral cortex and periventricular white matter. In connectors, mainly basal ganglia and substantia nigra, all the globus pallidus, all the areas. Now, how do you follow this baby?
Mm. Sir, we follow in high risk and just neuronal examination on follow-up.
Yeah, this babies be under our neurodevelopmental OP basis follow, because that at the time of admission the jaundice level beyond the threshold. So this baby should be under that register.
Any other question from the
That's it
faculty?
from my side.
Okay. Anything
That's it
from the
from my
audience?
side.
I think there is no any question
Congratulations.
from there is no question from the chat box. Any other question from Dr. Svetal Madam or Kunal?
No, no. We can speak.
Hello.
Vishal, we can
Yes,
conclude
yes,
the
yes.
session.
Yeah. So thank you so much. I think Dr. Asi really presented nicely, and I think Manan and Dr. Karthi already covered the lots of question, which is newer for few delegates or everyone. So thank you so much for doing this session, Dr. Karthi and Dr. Manan. I just want to ask the Dr. Vaishali, do you want to add anything on, because she's the mentor of the Dr. Ashi, so if you can add anything further. Dr. Vaishali?
I think she has left. Uh,
Okay, no worries. So thank you so much. Thank you, Satal madam. Thank you, Kunal. Thank you, Gati. And thank you, Manan, for doing such a nice session. And I think we'll be back next week, I think, with the new schedule. Thank you so much.
Thank you,
Thank you.
Vishal, for yeah.
Thank you.
Thank you,
Thank
Madam.
you.
Thank you, Isha.
Thank you, ma'am.
Thank
Thank you,
you.
dear
All the
doctors.
best, Arti, for the further course throughout your graduation, post graduation.
Yeah.
Thank
Thank
you,
you.
everyone, for sharing such valuable insights. I hope you had a seamless experience. And thank you once again for extending us this opportunity. Looking forward to host you again very soon. Till then, stay safe and healthy, and goodbye to all.